Well, thank you guys so much for having me today. I really appreciate it. I know it's been a long, eventful day for you guys, so I appreciate you sticking around for the last talk of the day. Like mentioned, my name is Kavitha Selvan. I am a clinical instructor of medicine at the University of Chicago, where I did my fellowship in pulmonary and critical care. And currently I specialize in the care of patients with interstitial lung disease. And so today I'm really excited to chat with you guys a little bit about what interstitial lung disease is. I'm sure some of you in the room maybe have heard that term or are familiar with it, but hopefully we can go into a little bit more detail today. And really what I'd like to do is give you some of the early signs and symptoms for recognizing interstitial lung disease, because it can be a diagnosis that's frequently missed and really important for a population of patients with scleroderma to be aware of. So that's really my goal today, is just to heighten your awareness and give you some basic information about what interstitial lung disease, or ILD, really is. I don't have any disclosures today. So for the next 40-45 minutes or so, what we'll talk about is what is interstitial lung disease, which patients or what populations are at risk for developing interstitial lung disease, or ILD. I really want to dive into some of the signs and symptoms that your doctor might notice on exam, you might notice as you're living your daily lives, that can kind of heighten your suspicion for a potential diagnosis. We'll talk a lot about the type of testing that's required to diagnose ILD, and then specifically, if you do end up with a diagnosis of ILD, what we do over time to monitor that disease and to monitor potential progression of that disease. And then finally, we'll end the talk today with treatments, specifically for scleroderma-associated interstitial lung disease. Some of these medications will be familiar to you, some of them might be new, and so we'll talk a little bit about the specific uses, and we'll even dive a little bit into some of the evidence, some of the medical evidence behind why we use these drugs in interstitial lung disease. So starting with what is interstitial lung disease, it's really an umbrella term, and it encompasses a lot of different diseases, in fact over 200 different diseases that lead to inflammation or scarring of the lungs, and sometimes both. That term scarring can be used in a lot of different ways. You might hear scarring, you might hear pulmonary fibrosis, and you might hear ILD. And people kind of use those three words interchangeably to mean scarring of the lungs. Those two different underlying words, so inflammation and scarring, represent what I like to call different flavors of interstitial lung disease. And so a patient might have predominantly inflammatory disease, they might have predominantly fibrotic disease, or you can have a combination of the two. When we talk about ILD, what happens is the walls of the air sacs of the lungs, which are called the alveoli, the tissue that surrounds those air sacs, and the space in between can all be affected by that inflammation and scarring. And so you can see here in the figure on the, I don't know if you guys can see mine, yeah, perfect. On the left-hand side, you've got normal lungs. You can see these little circles right here that look like grapes, or alveoli or air sacs. You'll notice that the wall of these air sacs are really thin. They're just, a single line, very, very thin. And that's what normal air sacs should look like. On the right-hand side, you see what this can look like in patients with interstitial lung disease. So the air sacs have become sort of larger and distorted. There's lots of thickening around the walls, all this extra pink tissue that you can see. And all of that is deposition of fibrotic cells and inflammation that can lead to this appearance of the lungs. So who is at risk for developing interstitial lung disease? There are sort of two big buckets of ILD that I like to think about. The first bucket is when we know what the cause is, and the second bucket is when we don't know what the cause is. And that, when we don't know what the cause is, it's termed idiopathic. Even within this idiopathic bucket, there are several different flavors of ILD. One of the most common flavors of idiopathic ILD you might hear of is called idiopathic pulmonary fibrosis, or IPF. ILD can be a little bit of an alphabet soup, so we'll try to simplify it. But you might hear of that. You might hear there's commercials that you might hear, or news advertisements for IPF. It's one of the more severe flavors of disease, and it kind of falls into this idiopathic bucket. Within the bucket of known etiology, there are sort of several different things that we can think about. Inhaled exposures is a main category, and when we think about exposures that cause ILD, we think about prolonged exposure to asbestos, Silica, so perhaps people that do a lot of stone cutting that are inhaling some of the stone can have deposition of silica in the lungs. We thought about coal dust and coal miners' disease. Birds can cause ILD as well, so that's called hypersensitivity pneumonitis. Exposures to molds, haze, farmer's lung is kind of the colloquial term for that. So lots of different exposure-related ILDs. The next bucket that we think about are drugs and then radiation. And so some of the common drugs that are most implicated in causing ILD, nitrofurantoin is an antibiotic that's commonly used for chronic urinary tract infections. Amiodarone is a medication that we use for conditions of the heart like atrial fibrillation. Methotrexate and other chemotherapies are medications that can be used in autoimmune disease and then certainly for cancers. And then radiation, typically the radiation we think about is that's associated with therapy for cancer. All of those things can lead to ILD. This third bucket is going to obviously sound familiar to everyone in this room. Autoimmune disease is a big bucket of causes. And so within that, of course, it wouldn't make sense if scleroderma weren't there because I'm here today. So scleroderma is a big cause. Rheumatoid arthritis, Sjogren's syndrome, the autoimmune muscle diseases or myositis, vasculitis, and lupus are some of the other autoimmune diseases that can be associated with interstitial lung disease. And then finally, the last bucket we think about are certain genetic mutations. And so there are people that have ILD that kind of runs in the family because of different gene mutations. So today, we're obviously going to focus in on this autoimmune disease bucket and this specifically ILD as it relates to scleroderma. So almost 50% of patients with scleroderma will go on to develop ILD. There are certain risk factors. You can see that range on the screen is 35 to 53%. And there are certain risk factors that can sort of put you on the higher end of that spectrum versus the lower end of the spectrum. And in fact, the lung is the second most commonly affected organ with scleroderma. So ILD is sort of one of the main manifestations that we think about in the lungs. Another pulmonary manifestation of scleroderma that I won't go into today in detail, but I'm happy to answer questions about is called pulmonary hypertension, or sort of high blood pressure in the right side of the heart and the pulmonary arteries in the lungs. And both ILD and pulmonary hypertension can lead to lots of symptoms, respiratory symptoms like shortness of breath, low oxygen levels, things like that. Risk factors for developing ILD specifically within the scleroderma population: male gender has been associated with higher rates of scleroderma, an older age at diagnosis of scleroderma, African American race, the diffuse cutaneous form of scleroderma as opposed to the limited form, and then certain antibody profiles. So many of you are probably familiar with the sort of battery of labs that get sent off when your rheumatologist is looking to make a diagnosis of scleroderma. Some of those labs include autoantibodies, and so if you end up with a positive SCL70 antibody or a negative anti-centromere antibody, those two things will increase your risk of developing interstitial lung disease. The course of disease with ILD can be really variable, and there are sort of three different phenotypes that patients might experience. About a third of patients will have relatively stable disease over time. Their lung function will remain relatively stable over time, and their symptoms will remain relatively stable over time. A percentage of patients will have disease progression, so decline of their lung function, followed by a period of stability. And then another proportion of patients will experience progressive interstitial lung disease. And even within that progressive disease category, there is still substantial variability. So you can see here from this graph, some people have a very slow progression of disease over time. You can see on your y-axis, this says percent FVC, that's forced vital capacity. It's one of the measures of lung function that we measure over time, and I'll talk a little bit more about that in detail later. But you can see, lung function on the y-axis, years since diagnosis on the x-axis. Some people have a very slow decline. Some people have a more moderate decline, and then there is a proportion of patients that will have sort of a rapid decline in their lung function as well. And this data sort of all comes from a large scleroderma database out of Europe. And a lot of data from this trial found that of those that have progression in the first year of diagnosis, half had further progression over the next 5 years. And so progression over the first year is predictive of progression over the subsequent years. Interstitial lung disease in scleroderma is the leading cause of morbidity in scleroderma. And this is why I mentioned those sort of inflammatory and fibrotic sort of flavors of ILD. The outcomes in patients that have predominantly fibrotic disease are worse than those that have predominantly inflammatory disease. I do think this point that I have on the slide here is really important. Outcomes with scleroderma-associated ILD are significantly better than what are seen in patients that have idiopathic pulmonary fibrosis, which is sort of the most common flavor that you hear about in that idiopathic bucket. When patients get this diagnosis of ILD, rightfully so, they want to learn about their health, they go home, they Google ILD, and the statistics that pop up are pretty much uniformly for IPF or idiopathic pulmonary fibrosis, and those statistics can be scary. And so I think it's really important for us to sort of know about the different flavors of ILD and know that some statistics are not going to at all relate to you guys and other statistics might. And so that's why it's just important to remember things that you read about, things that you hear about on the radio, on the ads and things like that are typically talking about a bucket of disease that behaves very differently than the type of disease we see in patients with scleroderma. So because of this, disease course being very variable, it can cause a lot of symptoms and reduce quality of life for patients with scleroderma. Diagnosing this disease early and getting patients on treatment as soon as possible is really the key. I think I sort of mentioned this. You're most likely to progress in terms of your lung disease in the first 5 years following disease onset. And there are a few different factors that help us predict who is going to have progression versus who's going to have that more stable disease. So some of the risk factors that we evaluate patients for in our clinic and try to be very thoughtful about treating are gastroesophageal reflux disease, which I'm sure many of you are aware of, a very common comorbid condition in patients with scleroderma. And so anytime we have a patient with scleroderma, we always ask about symptoms. We always want to get that as best controlled as we can because we know that confers increased risk for having progressive lung disease. If at the time of diagnosis you have more than 20% of your CT scan of the lungs showing fibrosis, that's a risk factor for disease progression. If your lung function, based on pulmonary function tests, which we'll go over in a moment, are reduced at baseline, that's another risk factor for progression. And same if your oxygen levels at baseline are low. And then finally, we talked about sort of the antibody profile being related to your risk of developing disease. It's also related to your risk of having progressive disease. And so that same antibody, that SCL-70 antibody, if it's positive, you're both more likely to get ILD and more likely for it to progress. So this, I think, is the really important piece of this for everyone in this room. What are the signs and symptoms of ILD? What should you guys be on the lookout for? What should you be kind of thinking about? And what should your doctors be evaluating for when you come in for your clinic visits? So some of the signs that we see on exam are low oxygen levels, which of course is non-specific. It's not, doesn't mean you have a diagnosis of ILD, but it's one of the early signs that we can see in patients that have ILD. Digital clubbing, which is what this picture is, which essentially just means at the top you see the normal angle of the nail bed is sort of an acute angle. You can see in clubbing that nail bed angle becomes obtuse and distorted, and that's called digital clubbing, or hyperkeratosis of the fingers is another term that you might see in your notes on my chart. Clubbing, again, is a non-specific sign. It can occur in other diseases of the lungs and heart and liver as well, but it is sort of one of the things that we always are cognizant to watch for when we're examining patients. And then pulmonary crackles, which is why it's so important that your doctors are listening to your lungs at every visit. I'm going to see, I should have loaded this earlier. Let's see if this will work so that you guys can hear what pulmonary crackles sound like. Is sound hooked up? Okay, perfect. So that's what pulmonary crackles sound like. It can be very subtle. Obviously, we had really great sound quality in here today, so you could all hear that really nicely, but it can be really subtle. And it's why it's really important that when we listen to your lungs, This is the one time I'm really diligent about making sure patients lift their shirt in the back so that I can have my stethoscope on their skin and not on top of clothing so that I'm getting a really fine listen to the lungs. We want to listen everywhere too. Crackles can hide at the bottoms of the lungs, the lateral sides of the lungs, and even anteriorly. And so that's why, oh, go ahead.
Was that exhaling or inhaling?
So you can hear them either way on inhalation or exhalation. Yeah, you can hear them both. But so crackles, that sound, I mean, it's named, it sounds like, the crackle that you hear with the Rice Krispie Treat cereal, if everyone's ever had that and poured milk over it, it's that same kind of crackling sound. What that sound really is and why we hear that sound in the lungs of patients with pulmonary fibrosis is because those air sacs that have fibrosis depositing around them, that fibrosis makes the lung less stretchy. Normally our lungs stretch very easily with each breath that we take. But when fibrosis sort of develops around those air sacs, as the air sacs open and close, they kind of pop open and pop closed instead of opening and closing easily. And that popping of the air sacs open is what you hear with these crackle sounds. And so oftentimes crackles will be some of the earliest ways anecdotally that we identify patients with ILD in the clinic. They feel fine, their oxygen is normal, really no other sign to suspect interstitial lung disease, but you listen and you hear really fine crackles in the bottom of the lungs, and that can be sort of one of our early signs of, we probably need to get an evaluation going for interstitial lung disease. I will say there are a couple of other things that can cause crackles in the lungs. So fluid that builds up in the lungs, so pulmonary edema can also cause crackles. They tend to sound a little bit different though. The crackles that you just heard are called dry crackles. You can hear sort of wet crackles in pulmonary edema. So there is a difference, but it's not, the term crackles in general is not terribly specific. Okay. So what symptoms should you be aware of? So this is probably obvious. The most common, by far away symptom that you'll experience with interstitial lung disease is shortness of breath and a dry cough. So this is not the cough that you get, when you have a pneumonia and you're coughing up sputum or mucus. This is a really dry, kind of nagging cough. It can be mild or absent in early disease, and sometimes patients only experience symptoms like shortness of breath when they're exerting themselves. And so oftentimes you feel fine at rest and sort of only notice it when you're doing household activities, you're making the bed, you're folding laundry, and you might notice, I feel a little bit more winded than usual. It can be just sort of as subtle as that. Some of the other symptoms that you might experience are fatigue, weakness, discomfort or pain in the chest, loss of appetite, and weight loss. But what you'll notice about this list is these are all really non-specific symptoms, and that's what makes diagnosing ILD such a challenge. It's not that we don't know about it, it's not that we're not thinking about it, but it's very non-specific. And compared to other more common diseases, it's relatively rare. So rather than thinking about the zebra, people often appropriately think about the horses first, and so it can be missed or diagnosis can be delayed. It can also be mistaken for other manifestations of scleroderma, like cardiac disease, musculoskeletal involvement. All of those things can cause many of these same symptoms, and so it is important to have a relatively high index of suspicion. And importantly, some patients will be totally asymptomatic, like I said. I have definitely had patients that have come into clinic, they were in the emergency department because they had a fall and they, sprained their wrist. They ended up getting a chest x-ray or a CT scan of the lungs just as sort of a screening or a precaution, and they were found to have fibrosis of the lungs. They had no idea, they had no symptoms, no other reason to suspect disease. And so that is what, again, makes this a challenge, is that there is a good proportion of patients that will be asymptomatic for quite some time with disease. So that leads me to this big plug: don't ignore symptoms. Diagnosis of ILD can be delayed by 1 to 2 years in majority of patients. And those reasons for delays are many. So sometimes it's that you tell your physicians about symptoms that you're having, and maybe they just don't know what to do and don't order the right tests or kind of minimize your symptoms. Maybe it's that you yourself are minimizing. I have a lot of patients that said, I just thought I was, getting older and, I'm 70 and I thought I was just slowing down. I didn't think anything of it, that I was a little bit more short of breath. So sometimes it's just that symptoms are minimized either by your providers or by yourself. Like I mentioned, misdiagnosis can be common. Asthma, COPD, those are much more common lung diseases than ILD, presenting with very similar symptoms. Sometimes it's that radiologists aren't reporting the early imaging findings that we see on CT scans. And so I'll tell you again, I've had many patients in my clinic come to see me in the 2000s and they have a scan from the 1999 that already was showing signs of fibrosis, but it wasn't in the report. And unless you're seeing a pulmonologist, a primary care doctor is not routinely scrolling through the actual images of your scans. They're looking at the reports. They're relying on the radiologist to do the reporting. And so oftentimes those subtle findings of fibrosis or scarring or inflammation don't get reported because they're so minimal, and then they get missed. And then finally, referrals are often delayed for, again, many reasons. Maybe it's an insurance issue. Maybe there's not a pulmonologist in the area that you live, or maybe their wait list is 6 months long. I can definitely tell you at some of the academic centers, that is the case, that you're waiting 3 to 4 months to even be seen by a pulmonologist. So lots of different reasons that your diagnosis might be delayed. The most important thing to remember is that time lost, those 1 to 2 years or longer for some patients where we're not making the diagnosis, is lung function lost. And with fibrosis is not reversible. There are things that we can do to try to mitigate it, to try to prevent it from getting worse. But once the lungs are scarred, we can't turn back the clock and unscar the lungs. Inflammation can be reversible to a certain extent, but scarring or fibrosis is not. And so that time lost is really lung function lost. That loss of lung function, like I mentioned, can sometimes eliminate options for therapies as well. And so one of the therapies I'm not going to talk about in detail today because this could be a whole separate talk, is lung transplantation for when patients have really severe disease. If we don't catch it until it's too late, that might not even be an option anymore. When we are able to sort of shrink that time to diagnosis, we're able to get you on therapies that slow disease progression. We're able to promote your quality of life. We're able to get you engaged in supportive and palliative care therapies that can help improve quality of life as well. And we can ensure that you're a candidate for the therapies that we do have, like lung transplantation, like clinical trials. There's lots of research going on in the ILD world right now to improve the therapies that we have. And that's a really important part of being seen by a specialist too, is having the availability of those trials and different research studies, if that's something that you're interested in. So moving on to the type of testing that's required. How do we diagnose ILD? And then once you have the diagnosis, how do we monitor your disease over time? There are sort of 3 mainstays of diagnosis. The first 2 are the most important, I'd say. Pulmonary function tests are the sort of thing that we do to both screen and follow your disease over time. High resolution chest CT or HRCT is, again, sort of become the mainstay of how we make the diagnosis and how we can separate out scleroderma ILD from a different subtype or flavor of ILD. And then sometimes patients require more invasive testing. Bronchoscopy and tissue biopsy are sort of those more invasive tests that we talk about. And I'll talk a little bit about this too. But that's sort of a plus minus on whether or not you need that. For the most part, if you have a history of scleroderma and you've got fibrosis on your lungs, there's a good chance that the flavor of ILD you have is going to be scleroderma-associated ILD. And so typically we don't have to pursue these more invasive testing routes. So starting with pulmonary function tests, I don't know how many of you have had these done before or are familiar with them. This is what it looks like. So you'll go into sort of a lab, a pulmonary function lab, or sometimes we do them in the office, depending on sort of your doctor's office. And essentially what we do is we're measuring the different volumes in your lungs. We measure the total lung volumes. We measure the sort of normal volumes that you take at a kind of quiet, calm breath. We measure you exhale all the way out. We measure what's left in your lungs at the end of an expiration. So we're measuring lots of different volumes of the lungs. We're also measuring the resistance to airflow. And we're also measuring how easily gas is able to exchange across the lungs. So you can see here somebody performing PFTs. These can take up to an hour to perform, and physically they can be challenging. I remember as a medical student, they had us go to the pulmonary function lab and get these done ourselves so we could see what we were asking patients to do. And they're challenging, to be able to do these tests, well, and to get the best quality data from the tests. you have to be able to blow out or exhale for at least 6 seconds or longer, which can be really hard if you're short of breath. If you have a chronic cough, that can be really challenging. And you have to be able to perform a 10-second breath hold. And that can be really hard too, particularly imagine if you have sort of moderate lung disease already, trying to hold your breath for 10 seconds can be really hard. And these tests, sort of the results that we get from them are all dependent on the effort that goes into them. And so if you're having a bad day, if you have a cold and your doctor tells you to go get your PFTs done on a day that you have a cold, the data that we get might not actually reflect what's going on in your lungs. It's, sort of the least well that your lungs can do, but it's not telling me the best that your lungs can do if you're not able to give a good effort. And so oftentimes we have really phenomenal respiratory therapists that will coach patients through how to perform these tests, and that can make a huge difference too. We make you perform the maneuvers to measure these different volumes multiple times so that we can make sure that your effort is reproducible and sort of more accurate in terms of the lung functions that we're getting. And typically we monitor these tests every 3 to 6 months once we have a confirmed diagnosis of interstitial lung disease. And if you have, no confirmed diagnosis again, then probably screening once a year would be reasonable. And so here, this is the body box that we have you guys sit in. This is how we measure the complete lung volumes in your lungs. They have this little clip that clips your nose so that you can't breathe out through your nose. They have this little kind of scuba spout that goes in your mouth. And then everything that you breathe in and out goes through this box and gets measured. And then there are little resistors on there as well, so we can get a sense of the resistance in the lungs too. So this is a flow volume loop, and this is some of the data that we'll get from your pulmonary function tests. So on the left-hand side, you can see what a normal flow volume looks like over time. This is volume on the x-axis, so as we go to the right, the volume is increasing, and flow, or how fast air is moving. And so normally, when you look at this bottom scoop, this is as you're taking a breath in, you're breathing in, you start with all this volume. And then here you breathe out really quickly at first, so your flow gets really high as you start to breathe out, and then that flow starts to drop as you're getting the rest of the breath out of your lungs. This is what's called restrictive lung disease, which is the classic pattern that we see in patients that have interstitial lung disease. And so what you'll notice is that the shape of the loop looks very similar. It still has this sort of circular bottom part and this sort of conical top part, but what you'll notice is that the volume is much smaller. And that's what we see in patients that have interstitial lung disease, is that scarring and that fibrosis sort of shrinks your lungs down over time. And so there's less total volume in the lungs, and the air is able to move out faster because they're stiff. And so when you sort of stretch them out to take a breath in, and then you exhale, they kind of collapse quicker than usual because they're so stiff from fibrosis. So you see that sort of shortened appearance of the flow volume loop. And when you look in your MyChart to look at the results of your pulmonary function tests, you might see in the impression consistent with restrictive lung disease. The next sort of piece of the diagnosis is high resolution chest CT, or HRCT. And this has really expanded in the last several years to decades and has become sort of the mainstay of how we diagnose this disease. It's really the most sensitive test that we have, and it's non-invasive, which is really wonderful. So typically there are some things that we do a little bit differently in the sequences that we obtain for high-resolution chest CT in patients that we have a suspicion for ILD for, compared to, if you have a pulmonary nodule and you're getting that followed over time. So the differences for the ILD sequences are we obtain prone images, which is when you're laying on your belly like this, and supine images when you're laying on your back. And that's because sometimes when you lay on your back, which this is how I think everyone's typically used to getting a CT scan, you lay on your back, you go on the scanner. The bottoms of the lungs can get a little bit squished for different reasons. So if you have extra weight that you have, if you have obesity, that can sort of lead to the bottoms of the lungs looking a little squished. And that squished appearance, when we look at it in an image, can look very similar to what inflammation looks like. When we flip you on your belly like that, now we've gotten rid of the weight that's squishing the lungs there by flipping you over. And so those changes that we see from your back will disappear if it's truly just related to weight or other things like that. Whereas if it's caused by inflammation from ILD, those changes will be persistent both when you're on your back and on your belly. And so we get that extra belly sequence just to be able to really make sure that we're not misclassifying changes on the scan on your back that are actually normal. We also get images in expiration. So if you've ever had a CT scan of the lungs done, you'll know they'll ask you to take a breath in and hold it, and then we scan you while you're holding your breath in and your lungs are maximally inflated. For ILD, we like to have an expiratory image too, because there are certain flavors of disease where air doesn't come out as well as it should, and so those areas will look different on an expiratory image than they will on an inspiratory image. All that's excessive detail, don't worry too much about that, but the point is, it is sort of it's not a regular CT scan, it is sort of a special CT scan that has a few extra views, and so your physician does have to have this in mind and be thinking, all right, I'm going to order the extra imaged scans here. The one thing, I've mentioned this is non-invasive, it's really sensitive, it's a great test, and it's what we recommend. We do have to consider that there is radiation exposure associated with the CT scan. And so with these high-resolution chest CT scans that we use for ILD, there's anywhere between about 0.2 and 1.0 millisieverts of radiation exposure. To put that into context, it's about 12 times more than a chest x-ray is, but I will say it's about 6 times less than the other types of CT scans that you get. So you're kind of in the middle in terms of radiation exposure, but what I will say is that it is by far and away our best test for making the diagnosis. And so if there is a high index of suspicion, absolutely worth the exposure to get these images. I do think, though, in years past, we have sort of periodically scanned everybody with ILD every 6 months, every year, just to kind of keep an eye on things. And now the field is moving towards being more cognizant of, we don't want to expose people to unnecessary radiation if we don't have to. And so we really are thoughtful about how often to repeat the CT scan. But getting one in the first place, I wouldn't say no to that for the radiation. So here's what I'm going to go through, sort of what these CT scans might look like. And really what I want to do is I'm going to highlight, maybe some of you are looking through your radiology images, but I think a lot of you will have access to radiology reports. And so what I really want you to pay attention to in the next few slides are there's going to be little text boxes with words that you might see in the report. And those are the words that I want you to kind of keep in your brain. So first we'll start with normal. Here's a normal slice of CT. And so what you're seeing is we're taking slices of you from your head down to your toe, and we're kind of cutting you in cross section. So you're seeing a cross section right here. Here's front, here's back. CT scans are strange, like x-rays, everything is flipped. And so the left is on the right-hand side of the screen, the right is on the left-hand side of the screen. Here's your heart in the middle, and then here are your lungs on both sides. So this might have caught your eye of kind of what's going on here. Is this normal? Is this abnormal? This collection of sort of circles that are filled in and not filled in. So here's that sort of same picture blown up. You can see there's sort of a black circle with a really light out gray line, and then there's a filled in gray circle. And so what you're seeing are blood vessels and airways cut in cross section. So imagine both blood vessels and airways are kind of running like this, and we're just cutting it in cross section. And so you're seeing it as a circle. In other parts of the lungs, like right here, for example, you're seeing it cut this way. So you're seeing it look like a line. So here you can see the airway is this black air-filled structure. The blood vessel is this gray blood-filled structure. And what you'll notice is that the airway is smaller than the accompanying blood vessel. That's what's normal. So now we're going to go to a patient with scleroderma-associated ILD. This is the same cut of the CT scan. This is the heart in the middle. Don't worry, this is the diaphragm coming into view. This is not some big abnormality or anything like that. That's just the diaphragm popping into view. But what you'll notice is there's a lot of gray, this sort of kind of see-through gray that you're seeing here and here, everywhere that there's arrows. And you might notice that kind of looks like ground glass or like that kind of see-through glass. And that's exactly what we call these. We call them ground glass opacities or GGOs. And this is a sign of inflammation in the lungs. And so this is one of those key terms that you might see in your radiology reports, ground glass opacities. This can be nonspecific, so other things can cause ground glass opacities, but it is one of the sort of key features of inflammation in ILD. This is another CAT scan, and you can see this is a really severe case of ILD. This is a patient with scleroderma ILD who has predominantly fibrotic disease. And so here what you see, I'm going to zoom in on this area right here. Think back to that same normal anatomy that I showed you a couple of slides ago. You had a small airway, you had a larger accompanying blood vessel. What's happened here is that fibrosis has been laid down around the airways. That fibrosis puts stress on the walls of the airway and pulls that wall outward. And as that wall pulls outward, it expands, and it becomes huge. And so that's what you're seeing here are large, expanded, distorted airways. And fibrosis that has sort of pulled these airways open and led to this scarring. You might notice that the lung kind of looks like honeycomb. And so in fact, that's aptly what this has been named. Honeycomb fibrosis, honeycombing, honeycomb cysts, and then traction bronchiectasis is sort of the other term that you might see. Traction meaning we're kind of pulling open, bronchi meaning airway. So these are sort of classic features of severe fibrosis that you can see in patients that have ILD. And then finally, here's an example of a patient with scleroderma ILD that has both inflammation and scarring. And so right here, this is sort of a different pattern that you see. You see kind of this pattern of lines that kind of look laid over like this. It kind of looks a little bit lacy. We call these reticular opacities or reticulation. This is another feature of fibrosis. And then here you can also see with this arrow, there's some of that same kind of smudgy gray or that ground glass. And so here again, ground glass is that inflammation pattern, reticulation right here, or that lacy pattern is our scarring. And so this patient has a flavor of ILD that is both characterized by inflammation and scarring. And so if you can key in on some of those key terms, you might notice them getting written in reports and things like that. And these can be some of the terms that clue us into early interstitial lung disease. Finally, I'll talk a little bit about bronchoscopy and tissue biopsy. So bronchoscopy is a procedure that we can do in the procedure suite. It's typically performed by either a pulmonologist or an interventional pulmonologist. And typically it's done as an outpatient procedure. So this is something you would come in for the day and typically go home later that day. It depends on if you're getting biopsies taken or not, but either you get some sedation through an IV, sort of similar to what you might get with a colonoscopy that gives you that sort of twilight sedation, or if you're getting sort of more invasive biopsies taken, you might actually get general anesthesia and be put to sleep with a breathing tube. So what we do is you can see here's sort of the bronchoscopist. This is what it looks like. It's sort of got a piece that you hold in your arm with levers that allows you to move the scope. Here's what the scope looks like. It's a long, flexible tube. It's not much thicker than like the cable for a computer up here. So it's not a particularly large scope. It's much, much smaller than the scopes that you see for colonoscopies or endoscopies if you had any of those procedures. And then at the end of the scope, there's a light and a camera. And so this is sort of a screen that we can see as operators. We can see sort of this is what the inside of your airways will look like, and we can see sort of all the different branches of the airways and sort of navigate to the part of the lungs that's most abnormal on the scan to take samples from. Typically what we can do is we can either insert or lavage the lung with sterile fluid. So we can send in some sterile fluid, we can suck it back out, and then we send that off to the lab. We can look in that fluid for different distributions of immune cells, and we can also look for other things like infections or things like that that can cause abnormal findings in the lungs. And then also, if there's sort of concern about what diagnosis you might have, we can also take small biopsies or samples of the lungs. So we have little forceps that can go through the camera and take little bites of the lungs that can then be sent off to a pathologist. We can look under the microscope and get sort of a more definitive answer of what's going on in the lungs. In years past, bronchoscopy was the gold standard for how we diagnosed ILD, either bronchoscopy or even more invasive surgical lung biopsy, because looking at the tissue under the microscope is sort of the best test to know what's going on. But since CT has become so advanced these days, we're actually able to make the diagnosis with your medical history, your physical exam, and your imaging alone in majority of the cases. And I honestly, I think I sent one patient for lung biopsy with bronchoscopy 2 years ago, and that was because we were worried about potential infection on top of ILD. It wasn't to make a diagnosis of ILD. And so it's pretty infrequent that we actually have to pursue getting tissue in these patients, or in patients with scleroderma ILD. Like I said, I think the more common reason for needing to get these sort of invasive samples are if you have a history of ILD, you have new changes on your CAT scan, we're worried about infection, or you have a new nodule that needs to be biopsied. Those are the more common reasons for pursuing invasive testing, but it's relatively rare that we have to pursue invasive testing just to make the diagnosis. So finally, I want to talk about how scleroderma ILD is treated. And like I said, some of these medications are going to be really familiar to you, and then some of them might be new. The first sort of bucket of treatments that we have are immunosuppression. And so we know in the same way that scleroderma affects other organs of the lungs by sort of an immunogenic phenomenon, it can affect the lungs as well. And so suppressing the immune system often suppresses the inflammation and fibrosis cycle that's being propagated in the lungs. The American Thoracic Society actually just this year put out a clinical practice guideline where they reviewed all the available clinical trials, observational studies, etc., that have been performed in the realm of treatment modalities in scleroderma ILD, and they provided an evidence-based recommendation for clinicians for what to do. And so that's where this figure is coming from. And the sort of strongest in favor therapy for scleroderma ILD is mycophenolate. You can see there are conditional in favor recommendations for a few other drugs like cyclophosphamide, rituximab, and tocilizumab. We'll talk about all of these medications in turn, but sort of the strongest in favor is mycophenolate. And I suspect it's a medication that many of the people in this room are familiar with because it's also a medication that's started for other manifestations of scleroderma. I think that's the nice thing about scleroderma ILD is often when other manifestations of scleroderma are more quiescent and better controlled, the lung disease tends to follow, which is very nice. I think the obvious question before we dive into each of these therapies is when do you start therapy? And so initiating treatment really depends on the disease severity. And I like to think of sort of two camps. I'm a big bucket person if you haven't figured that out yet. So the first bucket is if you have sort of mild disease or disease that hasn't progressed over time. And then the second disease or bucket is if you have more moderate disease or disease that is showing progression over time. Whether that progression is very mild or moving faster, it sort of doesn't matter to me, but progressive is sort of in one camp and non-progressive and stable is in another camp. If you have really stable disease, it's very mild, you're minimally symptomatic, it's not progressed over time. Typically what we do is we start by minimizing risk factors, and so that might be making sure that your acid reflux is really well under control, making sure that you're not smoking or exposing yourself to other inhaled antigens that we know can worsen lung disease. It's monitoring your pulmonary function tests every 3 to 6 months and kind of keeping an eye on those things. If your symptoms start worsening or if your pulmonary function tests start declining, that's my signal to start treatment in those patients with mild or otherwise stable disease. On the other hand, if when I meet you in my clinic, you already have moderate disease, you're symptomatic, or your scans have shown that your disease has progressed over time, that's a signal that we shouldn't wait and we should start treatment right away. And so typically we start treatment with medications, oxygen if it's needed, which we'll talk about, pulmonary rehab, and then of course always treating your acid reflux and making sure that's under control. So let's talk a little bit more about these drugs, starting with mycophenolate. Mycophenolate mofetil, or CellCept, is sort of the other term that you might hear, has been shown to improve lung function in patients with scleroderma ILD at the 2-year mark. And when compared to other medications, so that cyclophosphamide medication that we showed in the second line, that's sort of a conditional in favor, it's better tolerated. There's less side effects compared to cyclophosphamide and actually improves survival. And so this is a figure that comes from the Scleroderma Lung Study 2 that was performed in 2016. It was published in The Lancet, which is a really big journal for us in pulmonary and critical care. And you can see on the x-axis there's time in months, on the y-axis is survival probability, and this dashed line is mycophenolate, and you can see that over time, up to 2 years, the survival probability is significantly higher than the group that was receiving cyclophosphamide. And so this is really one of the strongest evidence-based medications that we have for scleroderma. It's typically dosed at 500 milligrams twice a day at the beginning, and then we ramp you up to 1500 milligrams twice daily if you can tolerate it. The main side effects, as many of you might know, are diarrhea, infection, and then cancers, specifically skin cancer are the major ones. And so it is a medication that requires periodic monitoring. Typically, we'll monitor your blood counts and your liver function tests more frequently as we're adjusting doses, but once you're on a stable dose, we'll monitor that every 3 months. And the one thing to just be aware of is this is a teratogen, so it's important to avoid this medication in pregnancy. Rituximab is another medication that can be used for the treatment of both scleroderma and scleroderma-ILD, and it was in this sort of second line of evidence from the American Thoracic Society with the conditional in favor. The evidence for this comes from a meta-analysis or sort of a grouped analysis of 3 different trials that have been done in scleroderma. Only 2 of those 3 trials were specific to scleroderma ILD though. And so it's important we're extrapolating a little bit from scleroderma without ILD as well. But what these trials found was that there was a reduced decline in the forced vital capacity, or one of these markers of lung function that we use, by about 3% in the group that was getting rituximab compared to placebo. And depending on the trial you looked at, some trials looked at up to 1 year, some looked at up to 2 years. There was no significant difference in survival, however. So lung function decline was improved, survival was not, and that's why it kind of falls into that second camp of medications. There are patients where this medication can be really great for controlling other manifestations of the scleroderma, but if your main manifestation is ILD, this is probably not my first line choice. This is an injection, and so typically you get an injection on day 1 and day 15 of the month, and every 6 months we'll repeat that. Infection is sort of a main side effect of rituximab. It suppresses the immune system to a greater extent than mycophenolate, and so I think infection is more common with rituximab. Reactivation of hepatitis B is a really important consideration. You can have infusion reactions. And then there's a very rare side effect, but can be very, very deadly. And so progressive multifocal encephalopathy, or PML, is an infection of the brain that's due to a virus, and it can be caused by rituximab. Like I said, very rare, but because it is a really important infection to be aware of, it's something that we always counsel patients on. Same as the mycophenolate, if you're on rituximab, it's going to require monitoring, and so typically before we start you, we want to screen for hepatitis B. If you've got that, we want that treated so that we don't reactivate disease by initiating therapy, and then you'll get blood counts before infusions and then monthly thereafter. Even after you stop rituximab effects can sort of be very, very long lasting, and I'll say this was a real challenge during the pandemic. Patients that were on rituximab were very immunosuppressed. It was very difficult for them to clear their COVID infections. And so it is important that we think about your inherent risk for developing infection before starting a medication like this. We certainly wouldn't want to start it if you had any active infections as well. And that's true for all of these immunosuppressive medications. Tocilizumab is sort of one of the, I think, new kids on the block. So there was a really nice trial, the FOCUS trial in 2020, that showed that in patients with scleroderma ILD that were receiving tocilizumab compared to placebo, there was improved lung function at 2 years. And the way that they measured it in this trial was sort of difference in lung function from baseline. And so here you can see what this looks like. Time again on the x-axis, change from baseline of lung function on the y-axis. And you can see in the placebo and in the tocilizumab group, their lung function kind of started out a little bit below normal. In the placebo group, the lung function continued to decline over time, whereas in the tocilizumab group, they had a slight improvement, and then really the most important point, I take this as stability in lung function over time. And that's really what we want to see. I think it's not realistic to see huge improvements in lung function over time unless you have predominantly inflammation that can be reversed. But really what we want to see is stability over time. The other, I think, caveat I should have mentioned when we talked about pulmonary function tests is pulmonary function tests normally are going to decline with age. Your lung function peaks at age 30 and then it's all downhill after there. And so you will have sort of a slow decline in your lung function over time, and that's normal. That's everybody will have that, whether you have perfectly normal lungs or whether you have ILD. And so oftentimes stability is really what we really want to see. Dosing, this is an injection. It's a weekly injection. You can see there's some side effects like inflammation of the GI tract that can lead to perforation. That, again, is rare. Infection, like all of these immune suppressing drugs, inflammation of the liver, and then anaphylaxis. So this is typically a medication that will monitor you the first time that you get your dose. And then there, again, same screening. So screening for TB, because tuberculosis can be reactivated by this drug. So we always want to rule that out before starting it. And then blood counts and liver function tests are monitored periodically while you're on this medication. So those might have been some of those medications, at least, you might be more familiar with. We'll now move into a bucket of medications called the antifibrotic medications, and maybe these are sort of less familiar to some of you all, or maybe you've seen all the advertising because there has been a reasonable amount for that too. The antifibrotic medications, the name is sort of a misnomer, so antifibrotic medications can't reverse fibrosis, right? We've said that before. Once the lung is scarred, that scarring can't be reversed. Really what these antifibrotic medications do is they slow the progression of fibrosis over time. And so keep that in mind as we talk about these. There's 2 medications on the market, and only 2, which is kind of the crazy thing. And that's why there's so much active research going on in ILD right now. Again, that could be a whole separate talk. The one that is approved for patients with scleroderma is called nintedanib, or OFEV is the other sort of term for it. And this data that led to its FDA approval came from the Census trial that was published in 2019 in the New England Journal of Medicine. And so what they found was that patients with scleroderma ILD receiving nintedanib compared to placebo had a reduced annual rate of their lung function decline. And you can see the difference is quite substantial, and they measure that up to 52 weeks here. Nintedanib is a small molecule that binds to a specific receptor, and essentially what it does is it inhibits the production of growth factors. And so it's a little sort of unclear how all these medications work, but we do see that the inhibition of growth factor is helpful in slowing the progression of fibrosis. Importantly, about half the patients in the Census trial were concurrently on mycophenolate. And so that's important to note too, is this isn't a, choose one type of situation. Oftentimes patients are on both an immunosuppressive medication and an antifibrotic medication, depending on how their lung disease has progressed over time. I'll tell you, typically, if there's any inflammation, I like to target that as quickly as possible because, like we said, that's reversible. So if we can reverse any inflammation and prevent it from becoming fibrosis, great. That's usually what I'll start with. If we do that, or if I need a patient that has purely fibrotic disease, this is now what we're reaching for, the antifibrotic medications like nintedanib. Nintedanib has also subsequently been approved for patients with any subtype of ILD that progresses over time, or termed progressive pulmonary fibrosis, or PPF. So in addition to being used in scleroderma, it's really used in all of the different types of fibrotic interstitial lung diseases. The only other antifibrotic on the market right now is pirfenidone, or Esbriet is the other generic name for it. It's currently not approved for patients in scleroderma, and it requires further investigation. So this is something you might hear about in clinical trials, but not something that is currently being offered to patients with scleroderma. And the mechanism of action for this drug, we really don't understand how it works. It seems to have something to do with reducing mediators of fibrosis, but we really don't have a complete understanding of how that medication works. Finishing up treatment, so supplemental oxygen. Supplemental oxygen is something that certain patients with ILD will meet criteria for. We always measure your oxygen levels in the clinic, both at rest and with exertion, because like I mentioned, some patients will only have symptoms with exertion and might only drop their oxygen levels when they're exerting themselves. And so typically we'll check a resting oxygen level when they put that little pulse oximeter on your finger, and we'll also periodically monitor a 6-minute walk test. Well, we'll have you walk back and forth in a hallway as fast as you can for 6 minutes. We'll measure the distance that you're able to walk in that 6 minutes. We like to see that you're able to walk at least 1,200 feet in 6 minutes. And then we'll also measure your oxygen at the beginning of that test and at the end of the test to see if you desaturate while you're walking. For patients who at rest have an oxygen level that's less than 90%, there's pretty compelling data that starting supplemental oxygen continuously for 15 hours a day at least can improve survival. This data is sort of extrapolated from patients with another type of disease called COPD. There's not a lot of studies that have looked at long-term oxygen therapy specifically in ILD patients, but what I will tell you is that every major guideline, including the American Thoracic Society, recommends starting therapy in patients with a resting oxygen level of 90%. And so that really is what we do. And anecdotally, I would say patients subjectively can tell when their oxygen levels are low sometimes, but sometimes can't. I have patients that are sitting in my clinic with a resting oxygen level of 81% and feel totally fine. And so it's one of those things that it's important that we're actually measuring because symptoms don't tell the whole story. There are a handful of patients that will only drop their oxygen level or desaturate when they're exerting themselves. And so this is a little bit less clear on whether or not you need oxygen or would benefit from it. We consider starting ambulatory oxygen for patients that drop to less than 88% when they're exerting. And there's some data from 2018 that shows that it can improve your quality of life and improve your subjective breathlessness. But there's no compelling data to tell us that it actually improves survival. And so typically if I have a patient who's only dropping their oxygen when they're exerting themselves, I'll have a discussion with them on sort of what they think about starting oxygen. Some patients will say, I'm really symptomatic, I want to start it. I can tell I'm, mowing the lawn and I feel like I can't breathe. And so those patients might opt to start supplemental oxygen and just use it when they're exerting themselves and not use it when they're resting. There are other patients that say, I feel fine, I really am not ready to start oxygen, I don't want to start it, and then we can wait. So I think it's just sort of a risk benefits with the patient. The last sort of big bucket of treatment that I'll talk about is pulmonary rehabilitation. And I think some of you probably may be familiar with this as well. Pulmonary rehab is a supervised program, and there's sort of 5 main points of pulmonary rehab. They'll teach you different breathing exercises, and so oftentimes patients with ILD or even other types of lung disease will notice that specific activities make their shortness of breath worse. A really common one is bending over. Patients will say, if I'm trying to bend over to tie my shoe or do something like that, I feel really short of breath. And so a nice thing at rehab is they sort of teach you different ways to mitigate positional changes in shortness of breath. They also will start you on an exercise training program. The focus of pulmonary rehab is typically on high intensity exercises, more so than low intensity, but we do sort of the whole spectrum of exercise. There's a lot of education on your health and psychological counseling and nutritional counseling as well. And so it's really sort of a holistic program that's really wonderful. Patients will go to 2 to 3 sessions per week for 1 to 3 months. And I think the most important thing is the benefits of pulmonary rehab. I think it can be a little bit of a barrier, and especially, depending on where you live, depending on how easy it is to get to rehab. Sometimes I hear patients kind of groan when I bring it up and they're not super excited about something that's 2 to 3 times a week. But I think the benefits is what really pushes them over the edge. So patients that complete pulmonary rehab are able to walk longer. They're able to walk an average of 40 meters longer in 6 minutes. They have decreased shortness of breath, and on quality of life scales, they have improved quality of life. And so typically when I remind patients, there's evidence, there's trials, there's literature to show that it's not just something I want you to do and spend, 2 to 3 hours out a week. You'll actually have a benefit from your lung health. I think that tends to help. And then the really nice benefit of pulmonary rehab is that those benefits that you've gained will persist after you finish the rehab. And so typically the studies that I've looked at have looked at out to about a year, and benefits often persist out to that first year after completing rehab. And so it's something I really encourage patients to take those exercises that you learn, keep doing them at home after you finish the completion of the program, keep using those techniques that you've learned so that we can really prolong that benefit. The last thing I'll talk on, I think this is my last slide, is just a few additional therapies that I think are important. And these are kind of the no-brainers that your primary care doctors are all doing for you, but just important to remember within ILD. Shortness of breath can be caused by a lot of things, and so managing other medical problems that can be contributing to your symptoms is really important, and managing other medical problems that can be exacerbating your symptoms are really important. So tobacco use disorder, I don't need to belabor this point, but everyone in here knows that tobacco is associated with lung cancer, it's associated with smoking-related lung disease, it's associated with ILD. So making sure that not only are you not smoking, but that no one around you is smoking, you're not inhaling secondhand smoke is really important. managing obesity, which I think was really challenging during the pandemic because people couldn't go outside, they couldn't go to the gym, do their sort of normal routines. Obesity was really challenging, and I'd have patients who come in, they would be really short of breath, their pulmonary function test would look relatively stable, their imaging would look relatively stable, and that worsening of their breathing was because they had gained 20 pounds. And it's you know, it seems obvious, but it's not necessarily so obvious in the moment when you have a chronic lung disease like this. And so making sure that you're managing that and sort of keeping up with diet and exercise. Congestive heart failure is another common comorbidity that can lead to the buildup of fluid in the lungs and can sort of make changes in the imaging that we look at difficult to interpret too. So making sure that you've got a really good primary care doctor that's sort of on top of all of your chronic comorbid conditions. And it's not on the slide, but managing the acid reflux as well. Add that there. And then finally, you can't have a talk by a doctor without a plug for an immunization, right? So here's your plug for immunizations, just making sure that we're remembering to protect ourselves against anything that can worsen your lung health, right? So pneumonia, influenza, COVID, now RSV, we've passed the RSV season, but back in November, December, we were thinking about RSV in our older population too. Any lung problem that you get, any pneumonia, any viral illness that you get, if you have abnormal lungs to begin with, it can be so much harder to treat. If you're on immunosuppressive medications, it can be so much harder to clear. And so just making sure that we're doing everything that we can to protect you from those things is extremely important. I think that's all I have for you guys. So I don't think I left too much time for questions, but if you have any questions, I'm happy to stick around and chat. And then just thank you so much for being here today.